From this session for half an hour, we will show heart specimens for aortic disease and valvular disease and the rest of them. And as we have discussed already, the aortic stenosis is a very important disease for elderly people, and the comparison between TAVR and SAVR has many different issues we have together. So I'd like to review. Before I start, I'd like to ask Professor Park to have some comment on the surgical issue of the current era. That, in my understanding, there are so many changes in devices of aortic valve surgery. So, like advance of TAVR devices, and also the SAVR device also changed, and so current valve is very different. Give you some comment.
This is not. Sorry, I am substitute my colleague. Oh, sorry about that. I didn't prepare the.
All right.
Yeah.
So let me start to showing the structure of aortic valve and annulus and supravalvular structures and so on. Yeah, now you can see the parasternal long axis view showing right ventricle, ventricular septum, ascending aorta, and left atrium is like this, and mitral valve. And here you can see aortic valve clearly that Dr. Jo-Ik-sung has described very precisely what is the aortic valve annulus. Annulus means the lowest border of leaflet. So this point is right coronary cusp, lowest border of right coronary cusp. And also this is lowest border of non-coronary cusp, and left coronary cusp is in this side. So there is a annular plane, means this area. So, and the annulus is in part of a structure at the annulus of mitral valve, because on the left side there is the left coronary cusp is in front, and it is in continuity with mitral valve. So this part is supported by muscular structure, and this part is not supported by muscular structure. So, but clearly, this part is the narrowest border, and we call aortic valve annulus. And there is some little below is the left ventricular outflow tract, which may be narrowed. Particularly for elderly people in hypertension, the left ventricular wall is hypertrophied, and the direction of the aorta became like this, more like this. So the plane of TAVI device adjustment is very sophisticated. So maybe for expert cardiologists, they may just need fluoroscopy, but I think it's very safe to use APCIS or transesophageal echocardiography, that this line of annulus is exactly in alignment with TAVI device. That would be very critical. And also, we can see this is another kind of annulus, which we call sinotubular junction, which is also narrow. That is the upper end of aortic valve commissure. This is commissure, and this is sinotubular junction. We can see a little bit of atherosclerosis here, but it's almost not atherosclerosis, very mild. And there is a coronary orifice here. So, and also we can see membranous septum is not below the annulus, but it is in between the leaflet. So membranous septum is here. It's in the, this is non-coronary cusp, this is right coronary cusp. Membranous septum is in between this area. So the distance from the annulus to lower border of membranous septum may be possible, but it would be very inaccurate measurement because the shape is not really clear in this case. But what we understand for conduction system is that this anteriorly flat mitral valve is in continuity with non-coronary cusp and left coronary cusp, and there's a membranous septum. And at this point is where the conduction system arises as of left bundle branches. That means there is some distance from aortic valve annulus to the beginning of conduction tissue. This distance is the critical distance for to be safe for damage to conduction system. But clearly, the new advance of TAVR devices are made to reduce the risk of damage to this area. That means the structural compression applies only this area and not to this area. So, and then some kind of curtain will be placed here to reduce paravalvular leak. And also, the alignment of the commissure of TAVR valve would be similar to this area so that coronary orifice is free of any TAVR valve cusp, so that coronary intervention is still possible, in this case, right coronary cusp. And the other part, you can see left coronary cusp. Yeah, this is left coronary cusp. This is zoom out. Yeah, this is right ventricular outflow tract, and this is left coronary cusp. Right, and so on. So in this specimen, we can see very normal heart without any lesion pathology in aortic valve. But in valve with aortic stenosis in senile type or bicuspid type, the commissure is classically very clear. Only calcification applies to, it begins with this cusp rather than the commissure. In contrast, the rheumatic valve disease, the calcification arises from this commissural adhesion. And so when the surgeon removed the valve cusp for aortic stenosis, we can clearly see the leaflet with a sharp border of aortic valve and calcific nodules in the center of this area. So the annulus is rarely extended in calcification in aortic stenosis, but in advanced cases, calcific nodules is very big to produce immobile and so on. Any additional comment?
Just short comment, the aortic valve. In aortic stenosis, cuspid valve is calcification everywhere, leaflet, and sometimes annulus, sometimes calcified extend to the mitral apparatus, extend to the left ventricular outflow tract. So very careful for the mitral. Sometimes they extend more than 2 centimeters to the mitral annulus. So very careful. And sometimes the calcification is protruding in the sinus and sinus tubular junction. So very careful. And bicuspid aortic stenosis. In my opinion, bicuspid aortic valve is more higher calcium score, so more calcification. So depth scallop is more, I think scallop is more scalloped in bicuspid valve, annular calcification more severe, and sometimes the calcium, the length in bicuspid valve is quite high and wide. So sometimes during operation, the calcium removal is very difficult in bicuspid aortic valve sometimes. So another one is in bicuspid valve, tricuspid is always, you can see membranous septum between that, but in bicuspid valve, very difficult to find, sometimes difficult to find the membranous septum. So that is quite different situation in bicuspid and tricuspid aortic.
Yeah, it'd be really difficult because you don't see like this, but you see only from the aortic side to see through this hole. Is that right? Yeah, so surgeon's view is very limited to see, but clearly we can see the annulus leaflet attachment from the aortic to cut, and then you will see the membranous septum below, and so this is a very complicated and very critical structure from the aortic valve. And if I partly agree that Professor O.J. Kwon has emphasized the earlier intervention for aortic stenosis, that as we all agree that aortic stenosis is not a disease of aortic valve, but it produces many risks for myocardial infarction of left ventricle and left ventricular wall hypertrophy and interstitial fibrosis of myocardium are produced due to aortic stenosis. So the progression of aortic valve disease is not in the aortic valve, but in the left ventricular myocardium. And we have another issue will be atherosclerosis is usual for ascending aorta of this patient. This is not very classical case of atherosclerosis of aortic valve, but if I orientate this specimen, this is left ventricular wall, and we are opening from the anterior to show aortic valve. Aortic valve is enlarged to produce aortic valve regurgitation properly. You may recognize that there is a hole in the aortic valve, but this is no problem because this is not in the line of closure is below this fenestration. So this is not pathologic fenestration, but it's a kind of degenerative change of free lunar part of aortic valve. Aortic valve has nodulus aranti in the center, and line of closure is like this, and then over the line of closure to the free border is lunula, which is like a lunar 손톱 or the 초생딸 and so on. So and in this case we have no case of aortic valve calcification, but here is the membranous septum, and in this case the membranous septum length is very narrow, that it's also aligned with the lower border of non-coronary cusp and right coronary cusp, so that it's very short distance from the if TAVI is applied. And this is some comment.
You can see this valve is central recent valve. The strut is ventricular side. So the valve is slightly intra-annular, but some leaflet is the KG is in ventricular side. There is always, this is some subaortic pannus, something, but mild pannus. In ABR, single ABR, pannus is quite rare, but in double valve replacement, pannus is quite frequent after 10, 20 years follow-up. So this is not severe, but that is make some subaortic stenosis. Usually pannus is subaortic area, not supra-annular area. So sometimes supra-annular type of mechanical valve slight better, but seal mechanical valve have problem with panels formation.
Yeah, yeah. In contrast to the previous specimen, this has almost no no panels. That it is very clear for annulus exposed, but by the growing the panus structure, which is fibrinal exudate and organized fibrinous exudate around the annulus and to cover, and sometimes become the bigger one, and then the panus may produce another difficulty. Okay. And then I'll show some of the heart specimen with advanced disease of aorta and from autopsy cases. So this is ascending aortic arch, and this is aortic arch. And in the back of the aortic arch, there is a big space of like this. So it's a pseudo-aortic lumen, false lumen, to have this kind of big space with thrombocene. So it's a kind of, how do you explain? Yeah.
There is thoracic aorta descending thoracic aorta aneurysm formation. So probably, I don't know the cause of this. Some outside is some thickened, not ruptured thoracic aortic aneurysm.
Yeah. So there is a big, if we CT scan of this case, we'll see aortic lumen is not very much dilated, but there is another big space in the back of the aorta to have partly thrombosed blood-filled space and with communication with the main aortic cavity. So it's a false lumen. And then this is a case of aortic dissection. We are looking at the left ventricle with aortic valve, and in ascending aorta, the wall is split and the thickness of the inner part is two-thirds and outer part is one-third. So splitting in this plane is usual for dissecting aneurysm due to the Marfan syndrome or something like that. So there is a opening of this splitting. There is an opening here. Yeah, this opening could the degeneration of media of aortic wall was multifocal at the beginning, but by bleeding inside the degenerative focus in media could produce a space, and then suddenly the rupture of aorta could produce pressure to this space to make an extension to the descending aorta arch and ascending aorta to the aortic valve. But at the aortic valve, there is no more space for extension of the dissection, so it stops here. But that particular point is here. This is, as you know, this is a right atrial wall at the transverse pericardial sinus. So in the curvature of atrial wall, there is a hemorrhage, which is an extension of aortic dissection. This is transverse pericardial sinus. An extension of this hemorrhage comes through to this wall, transverse pericardial sinus, and hemorrhage. And also, this is very close to the AV node area, which is here. So this kind of extension happens from the dissection from the beginning, very small, and then extension to the level of aortic valve and atrial wall and descending aorta and so on. Any comment? I'd like to show some specimen with acute myocardial infarction and chronic myocardial infarction. This is an example of acute myocardial infarction. The heart is not enlarged yet. There is a hemorrhagic infarct at this part, which is anterior wall of left interventricular septum and anterior wall. So if we put this part together, it is like this. This is a recent case of cardiac transplantation in Bucheon Sejong Hospital. 60-year-old man with acute myocardial infarction with severe heart failure, sudden acute failure, and transplantation was done, and very successful transplanted heart. So it's right atrial and left atrial resection lines, and in the sectional plane we can see hemorrhagic necrosis in. Usually, this is not classical hemorrhagic necrosis. It's a solid organ infarction, so ischemic infarction with hemorrhage. So this is anteroseptal infarct. And if it progresses more, it progresses like this. This is a thinning of lateral and inferior wall of left ventricle, and this is anterior wall, septal wall. So in this case, right coronary artery territory is, and also left circumflex artery territory is involved to make a severe old chronic myocardial infarction, but it's still resolved. And after acute stage, this part is fibrosed and thinned and become aneurysm. So the contraction applies only this anterior and septal wall. And this is also another case of heart transplantation in Sejong Hospital. And another impressive case is also myocardial infarction. Okay, yes. Myocardial infarction. Wait, focus please, yeah. And as you can see, this is right ventricle, left ventricle, anterior wall is okay, septum is fibrosed, and the septal aneurysm begin, and also endocardium is thickened. At the apex of this heart, it was like this. So aneurysm starts from the middle of the left ventricular septum, and apical part is severest, and then there's a big mural thrombus in apex of left ventricular aneurysm. Of course, this produces much problem for systemic embolization from left ventricle to aorta and coronary arteries, and there was some ischemic attack to brain, but still after transplantation, he's still in moderately good condition. And okay, some comment. Finally, I'd like to show some case of valve disease in autopsy case series. So this is a case of in 1983, a 12-year-old girl, very young girl with rheumatic heart disease. In acute rheumatic fever, it's a pancarditis with endocarditis, myocarditis, and pericarditis. As you can see, the pericarditis is fibrinous pericarditis, and then after organization, this fibrin become a kind of hair-like structure in the pericardium. Bread and butter pericarditis is the classical for rheumatic carditis. In the myocarditis, we cannot see grossly, but endocarditis, we can see vegetation in the valve, but also after repeated episode of vegetation and healing, produce the this structure. Usually vegetation arises at the line of closure, so this free border is fibrosed and thickened in this case, and also caudal thickening and fusion is classical for this area. In this particular case, commissural fusion is not very prominent, but usually commissure is fuse between the line of closure. So when the line of closure has inflamed, the commissure is usually adhered to produce narrow the mitral valve. And in this case, we can see very big left ventricle. That means mitral valve was regurgitant, not only stenotic, but regurgitation produced left ventricle enlarged. And aortic valve is not yet prominent, but there is some fibrous thickening of free border of aortic valve, not very severe in this case, but usually aortic valve is also involved to rheumatic process, and particularly the line of closure of aortic valve will produce this kind of fusion to produce narrowing of aortic valve. This is one of the severe case of rheumatic, chronic rheumatic mitral valve stenosis, that left atrium is tremendously enlarged, and mitral valve show severe adhesion and commissure, and free borders are deformed. And particularly, if you look at the mitral valve from the atrial side, the size of anterior leaflet looks like bigger than mural leaflet. That means the lateral shortening of mural cusp could produce this length is shorter and this is still remaining big. That's because the anterior leaflet is very long from the annulus. So this part is not involved, but this part is involved. So shortening of this area, but this is not shortening. And commissure is severely shortened, and mitral valve is excised like this, and then prostatic valve will be applied to this heart. Some comment?
You can see the coda. Coda is quite thick, this one, shortened. The typical rheumatic valve disease. So sometimes pure mitral stenosis, we perform the open mitral commissurotomy along the commissure. This is shortened, usually then twice longer than quite short and thickened coda. Everything. Yeah.
And this is the last case. The mitral valve is another enlarged, but not all the commissure is the same involvement. But as you can see, this posteromedial commissure is severely affected, but anterolateral commissure is not very much involved. So there is some variation of this case, but still it could produce much regurgitation of mitral valve, so the left atrium and left ventricle together have tremendous enlargement in this case. Again, aortic valve is not very much affected in this case. If there is any more comment from the floor, we would. That case, please enjoy a coffee break. Thank you.